Well, welcome to demonstrating implementation excellence streams in SNOMED CT Expo 2025. Thank you, IQVIA, for sponsoring this stream. My name is Alejandro López Osornio. I'm a senior implementation specialist in SNOMED International. I'll be your moderator for today's session. We'll address all questions at the end of the presentation. For our online audience, please use the QA button to submit your questions to the presenter. For those attending in person, feel free to use the microphone provided in the room when the time comes. It's now my pleasure to introduce Thomas Decramer and Kristel van de Loock from University Hospitals Leuven, who will be presenting implementation and outcomes of SNOMED CT-based complication registration in the electronic patient record, an experience at the Department of Neurosurgery. Thomas and Kristel, thank you.
So can anybody hear me? Everyone can hear me? Okay, perfect. So thank you for the opportunity of presenting the work that we did at the Department of Neurosurgery with the support of our local SNOMED implementation team. To give you a short introduction about the center where I work and we work, it's University Hospitals Leuven. It's a very large hospital in Western Europe, even to German standard is quite large. It's 2,000 beds, the largest hospital in Belgium. And at the Department of Neurosurgery, we're with 7 staff neurosurgeons. I am one of the staff neurosurgeons, and we're with 7 to 8 trainees a year that are in the hospital. We perform about 2,000 surgeries a year. And this talk is a bit on how we can use SNOMED CT in a more clinical situation. It's a bit more low level than all these fancy AI talks. But just to show you that it's important for us to registrate, and this is where all the data comes from. We can do all the fancy AI stuff, but if we don't put it nicely in clinically and it's not reliable, we cannot do anything with it. So why would we do complication registration? It's because it's a very important thing in healthcare. And the World Health Organization has estimated that about 10% of patients are involved in an adverse event during their hospital stay, which means that's an important morbidity for the patient, but also a burden for the healthcare system. It costs a lot, and if we can avoid these complications, it would, of course, be a lot better. The idea of our neurosurgical complication registry, or the NCR, is to improve patient safety, gain insights in our own complications, and perhaps also it could influence surgical decision-making. If you can choose between 2 surgeries, and one has less risk in our hands than the other one, we might shift to the other one. And it might be different in the literature than compared to what we see in our own center. In the past, we have had multiple attempts to get this complication registry. It was a bit like starting in the Stone Age, where we had these forms that needed to be filled in that were in the electronic patient record, but it was always difficult to fill this in correctly. They were uncoded, a lot of free text, and especially you put it in a big pile, like in a big dumpster, and it was really difficult to put the data out. So we had to overcome an important IT hurdle, which means we had to have a full integration in the electronic patient record. It has to be user-friendly. We should be able to monitor the data, if it's filled in or not. Can we send reminders if somebody forget to fill something in or not? And the data should be accessible for all users who are involved. As a neurosurgeon, I want to see the data of my own patients. We want to see the data of our department. We want to discuss the data of our department. So these were all a lot important hurdles to overcome. The primary objective was to get quality improvements. The secondary was to have some kind of research enablement. If you want to publish about a certain procedure, we want to get the data. We want to know all the side effects and all these things. And also we want to make sure it was future-proof. It was also scalable, that you could adapt it in the future. It could also be easily enrolled to other departments. So this was a pilot project within the hospital. Just some context, the policy framework in Belgium. So in Belgium, SNOMED CT was adopted as a national standard. And the idea is from 2027, we will use SNOMED as a primary thing to set diagnosis in the EPR. This is very ambitious, I think, because not many hospitals are familiar with SNOMED. So it will be very important, and probably 2027 will be a bit early. In Europe, there is also a lot of work on the directives, European health data space. There's a very important emphasis on it should be interoperable, and probably this common language of SNOMED CT can help us a lot with this. So we first had to start with a complication list, and this was an iterative consensus process between the neurosurgeons and the clinical terminologist in our hospital, that we said, okay, this complication, we need this, and how can we fit this with the SNOMED terms? Because it's not one-on-one, so we had to discuss and see what makes most sense. We came up with around 100 complications, not in one patient, of course, but spanning everything. We divided them into 3 groups: intraoperative complications and postoperative complications, which were surgical, related to procedure, related to wound problems, and postoperative medical complications. For example, pneumonia, it's not really surgical, but it's something that is, of course, can be caused by the surgery itself or by anesthesia. Just to give an overview, this is a large list: intraoperative complications, postoperative complications, and we all map them one-to-one to SNOMED terms or to a combination of SNOMED terms. So every complication needed like a SNOMED translation. If you looked closely, we also had a 4th category. 4th category, no complication. You could ask, okay, the absence of complication means that there is no complication, but it just means that nobody looked at the file. So by doing this, by really stating there's no complication, we know for sure that somebody looked at the file, and that's how we could monitor how many of the procedures were mapped or how many of the procedures the complication registry was filled in correctly or not. We did some light post-coordination, meaning that we also combined certain SNOMED concepts. For example, a hemorrhage into the extradural space of the neurexis, which is an epidural hematoma. It can occur after surgery, but it can also occur after a traumatic brain injury. So we then said this is a hemorrhage into this space after a surgical procedure, which is a postoperative hematoma. So we combined it like that in order to be able to be sure that we could have a nice SNOMED code and it's also distinguishable from the other epidural hematomas, for example. There were some new disorders that were requested through SNOMED International, and they were especially device-related. For example, a problem with DBS electrodes, some breakage in a DBS electrode, all these things is not mapped in SNOMED already. So we noticed a lot of device-related things. We had to ask for them to make some new codes as well. So how does it work? So we have a surgical procedure, which is in the EPR. You see it there, it's a sexy hypophyseal tumor, it's resection of a pituitary adenoma. And then you see these linkage buttons below. And that means that you have a complication linked to that procedure. So the complications are not linked to a certain hospital stay, they're always linked to a procedure. And we did it like that because we're neurosurgeons, and for us it makes more sense to link it to a certain procedure. We record all the complications that occur within 30 days of the procedure. This spans almost all complications, I think, and we have to have some kind of cutoff where we can, for example, close off the file. Otherwise, if you have to do it for patients that were operated a year ago, it's almost impossible. Who is responsible for filling this? It is a trainee who assisted during the surgery or did parts of the surgery is responsible to fill this in. Just a short overview how it works. This is fully integrated in the EPR. We have a complication button. We select the procedure, and it says there's a postoperative complication. It's a hematoma. It's a postoperative epidural hematoma. And then this SNOMED code appears in the file. I will show some results. And apart from SNOMED CT, the next biggest revolution that we had was that we have this data warehouse integration. So everything used to be in the EPR. It was very difficult to get something out of the EPR. And now the hospital had some pilot projects where we get all data, all structured data from the EPR into a large data warehouse. And with this data warehouse, it's very easy to integrate tools like Google Looker and these things to check this data. It's easier to program yourself. Everything appears there, also lab results. Everything that is structured will appear in this data warehouse. And that allows us to give some real-time patient overviews. This is, for example, how the dashboard looks like. where we can see the amount of procedures that have been performed, the amount of procedures that were uncomplicated, the amount of procedures that were complicated, and also the percentage of procedures that were registered. And we monitored like that using this no complication or a complication, then we know for sure that it was registered. We also have a bit of a wall of shame at the right lower corner. These are the trainees that's for the ones that were not filled in already. So these remaining 6%, these are the trainees that were responsible for most of them. So if your initials are GV, you have a problem, and we will tell you you have to fill everything out, or you will not attend surgery anymore. Okay. We can also look at it in a different way, which is of course more interesting. We could see which complications appear the most. If you click on these, for example, on this motoric dysfunction, you click on it, you get a list of all patient record files and just all the patient record numbers. If you click on this patient record, then it automatically opens in the EPR. So it's really easy to monitor your morbidity and mortality and open these things depending on the complication that you want to investigate. So we have this SNOMED implementation in the EPR. We have this very nice IT data warehouse and data extraction. But of course, one of the biggest problems is the system works perfectly, but we have to input the data. And the question is it reliable or not? We did some analysis on a sample of these patients among the 13 trainees that were involved. The gray ones are the ones that they said there was no complication, it was correct. The green ones were the ones that they had to do something and they registered a complication. And the red ones were the ones that they said there was no complication, but there was a complication. It's always remarkable that there are no false positives. So nobody will say there is a complication and there wasn't a complication. It's always they don't see the complication and they choose an easier option. And it's something that we have to really address. It's not easy to address this, I think, but we're trying to do some things to do it, and we want to monitor this data quality as well. It's still time consuming for the clinician, but it depends a bit also how you look at it. If you say, I will look at 30 days after the surgery and to see if there's a complication, I will look at the entire file, I have to look at everything, and then it's very difficult. But if your colleague sees somebody at the emergency department after the surgery and says, I will fill in the complication because it occurred now, then it's a lot easier and it's just some kind of check. And I think that's the best system to do. Some things that we're trying to address in the future as well is that we want to include the Clavien-Dindo severity grading, which has also been approved by SNOMED, that we could link it. And this is a scale for the severity of a complication. And you could say this complication results in death. That's of course more severe than this complication results in headache. And a postoperative bleeding can result in headache or can result in death. So it's really different. And that's something that we should really address, especially for the surgical complications. We want to also expand to other departments where probably the most early department at the moment are all the surgical departments, and we want to make a common set of SNOMED CT concepts or complications for the surgical departments, and then probably have one specific for neurosurgery, cardiothoracic surgery, and all these things, because it's just completely different worlds. But we also want to have this common set, for example, wound problems, all these things that we could really expand it more on a bit of a high level basis, I think. We also set the first step in automation, not through fancy AI models, but through just human intelligence, where we looked at certain files. So everything in the data warehouse, everything that is in the EPR, structured data, we can look at. For example, lab results, we can look at the medication that the patient received. We can look at if they received antibiotics or not. For example, we defined a few triggers. For example, somebody received more than 5 days antibiotics within 14 days after surgery. It's highly likely they has an infection, and that these things can come up through this. Or somebody who presented to the emergency department within 30 days after surgery. Again, it's easy to pick this up, and that also can help the trainees to fill these forms in, because we now made a system where they can see where they Can see all the procedures where they were involved, the ones that had a filled-in complication register or didn't have a filled-in complication register, and they can see which trigger went off in this list, and this can help them to probably fill in this complication register in a better way. So to conclude, we think it's feasible and clinically useful. It could have a direct impact on care and research enablement, and it's definitely scalable to other specialties. Yeah. This is the team, some neurosurgeons involved. Dominic Bruinings, who is our clinical support manager, put in a lot of work, especially with the integration with this data warehouse, which is also the IT department. And then our local SNOMED team, also Kristel van der Loock, who also was here to present if I could not make it. This was everything that we wanted to present. So if there are any questions, happy to take them.
Thank you very much. Well, thank you, Thomas and Kristel. We will now begin the question period. As a reminder, if you are in the room, please use the microphone to ask your question so that everyone can hear clearly, especially online. We have a question in the room.
Hello, my name is Marte from the Norwegian NRC. Very interesting presentation. Thank you very much. Are you willing to share the data sets on how you combined the different complications with the different procedures with other countries who might be interested?
I think it would be nice, to collaborate on it now. If Kristel, she put in a lot of the work. I don't know how much she charges for this, but no, I think it will be possible to share it, of course. It's not something extremely high level, but it's something that we did for neurosurgery, and I think it would be useful if we could have some kind of European standard for this is the European, like this is the neurosurgical complication that we want to look at, and it's registered in the same way. You could also collaborate on a bigger scale with the hospital. Yeah.
Yeah, but the codes are in the local language, but that SNOMED CT will fix that. As long as we have the codes, we can look at it. And thank you very much. That can inspire us for other areas of surgery as well. So thank you again.
Okay, no problem.
Have other questions in the room, in the front?
Thank you for this very interesting insight. I have one question regarding complications. I'm myself responsible for the MZG, which is ICD coding. Mm-hmm. And one of the problems we see is that there's a lot of complications that are not seen as complications by the clinicians. Isn't that a big danger of bias by making this kind of system instead of doing the other way around, seeing what happened with the patient and then trying to make conclusions? Or am I jumping the train there?
Yeah. So it's definitely sure that we have to discuss what is a complication, and it can be some things. What is it unexpected, or is it something that we might expect as a complication or not? Some things are a bit deviating or not. We are really trying to train the residents that everything that is not normal in this postoperative course is a complication. But the complication is not something dirty and you should not have it. It's something that just occurs after surgery. Complication is not something that you get sued for. It's just a complication of a procedure, and you should record them really at a low level. If you say we'll look at the data of the MZG and for the international...
I wasn't referring to MZG as that. I was referring to what's in the file.
Yeah, what's in the file, but then you also see... I'm not sure that everything in the file is that correct as well. So, and then you look at, for example, for the reimbursement for the government, if they had a pneumonia, you get some more, and everything. It's more like a bingo chart. And everyone's like, yes, 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 yes. Oh yeah, we get more. But it's also not the best. Also not the best solution. Huh? Probably then a lot of people are getting a bit on the higher side of the complications to be able to record and to be sure that they can really say, okay, this patient, instead of 2 days, he can stay here 4 days, and it's okay.
I can reassure you on that. The complications are excluded, so
okay,
they don't weigh.
Okay, but it's a difficult system. Yeah, it's a difficult system. Of course, that's some common understanding of what a complication is. But now at the moment, a lot of people, it's like, oh, complication, oh, I cannot have complications. Yeah, then you should not operate.
Thank you.
And one more question from the room.
Thomas Dieberts was Charité. Thank you very much for the talk. Have you considered looking at attribution strength? Because maybe it's easier in brain surgery, but for example, in visceral surgery, it's sometimes very hard to exactly say this side effect or this complication is coming from exactly this sub procedure. So and then you have, and also for hematoma, for example, there might be no information in the files whether it was caused by something or not.
Yeah.
And this is why certain complications might have certain levels of attribution strength, like you do in medication. Have you looked at that, or is that still
No, it's a good question, but it's the same as the severity grading. The severity grading, I think, is the first step. And then you could see, I mean, if you have a bleeding in your brain after brain surgery, then chances are quite high that we did it. But it depends for other things as well. But I think everything that occurs within 30 days after surgery, you could say a pneumonia. You could say, okay, but he's at home 3 weeks later. But yeah, okay, it's also quite a coincidence that he gets a pneumonia. So I think it should be recorded because he was ventilated for a couple of hours. Chance of him getting a pneumonia in the next month are higher than when he would just be at home. But he can also just get a pneumonia. But I think the first step is really to record his. And then the next step is, okay, do we think it is through surgery or not? And that's something that we can also look at if you have a morbidity and mortality discussion. We can say, okay, now we will look at the patients who presented within 30 days at the emergency department. And then we just have a list, and then...
I totally agree. You should record everything regardless of the cause. But I think because essentially you're also starting with the devices and you're attributing some complications to the use of certain methods or devices. And this is why I'm asking.
Okay.
Any other questions? I'm checking online. Yes, we have one more.
What problems would you see or would you think of when you would like to expand this to more hospitals in Belgium, at least?
So one of the big hurdles is, I think, the EPR. If it's the same EPR, it's easily transferable, and a lot of hospitals use the same EPR, so I think it should be transferable. The data warehouse integration is quite unique for our situation. So to look at this data, I think is quite unique. Otherwise, you will always need to have help and ask somebody, can you please look at this data? Because now every 24 hours, everything is updated. So we can just look at everything. So I think that's also something that's probably missing. In other hospitals, they don't have as many trainees. So the question is, is there going to be some kind of financing from the government to, for example, hire a clinical support manager who can sustain this kind of ecosystem, because it's a lot of time consuming. That's also why we are looking in these automated methods and see if we can improve it that way, because otherwise it's all retrospective patient file reviews, which nobody wants. Of course, if the government goes for SNOMED, also for the reimbursement and everything, then you could gain a lot of manpower from that department in order to get this in a better way. But we already notice it's quite difficult to go within the hospital to other surgical disciplines, because everybody is a bit different and everybody has their own 200 complication list. And that's something that we're now trying to do, that it's a bit more common and that we get this more common concept. But then I think we could definitely enroll it to other hospitals, probably first if they use the same EPR. And then it depends on the other EPRs if they can also integrate this kind of thing or not.
Okay, thank you.
Okay, thank you, Thomas and Kristel, for an excellent presentation.